Oh. Hey, Jim.
Hey guys, how are you?
Good. How are you?
You're so early.
We were like, we wonder if anyone will be in here.
Yeah, I'm just opening up now. I'm going to step away, but I just wanted to have a slide ready when people came.
Okay,
Um,
cool.
we're up to 233 people now, so we
Oh my gosh.
10 more.
Congratulations.
So we'll see how many show up. A lot of people, sign up for things and then they just wait for the email with the slides. But I think we're definitely going to have a big group.
Awesome.
So be ready.
We're ready.
Okay. So I'm going to help myself getting ready by getting some coffee going. So I'll be back here in a few minutes.
Okay, see you soon.
Okay, thanks.
Hey, Jim.
Need to bring something. So you can say, oh, we'll do drinks. Well, actually, it was Sheila next door, completely apart from all of this, who said, hey, are we still doing this? And then she said, if so, we'll bring brats. Somebody else came in and said, oh, we'll bring whatever. So people are just chiming in and saying, we'll bring this.
So, yeah, I guess you could say we'll bring beer and wine or something. Or just wine.
Well, it's Italian beef, so it's nobody wants wine with that. You know? So,
They will actually remember singing something to Mars. So yeah, something about Mary or however I'm glad it started.
yeah, so Sheila suggested for starting before. someone got a special call from their director about their comments about something.
We need that talk.
Okay.
Say more about that. Like if I can't say something, the director, that's so I said where can it be said?
I heard you ask, and by the way, you asked very diplomatic. So, yeah, well, it was, the one part of the side of the conversation I was hearing was very interesting. And so it was about the theatrics of wiping things down.
People coming in for client visits.
Yeah.
We're taking their temperature.
Yeah.
And they were laying out this information to the director's meeting this morning. And then I said, in the chat, I said, I would suggest look at ongoing public health thought and science around this. Because it may not be that useful. And Simone was like in charge of the small group who was coming up with these recommendations. So then I just put it in the chat. She said, oh, do you want to speak more to that? It's her and I had that conversation about this. So I said, it's kind of like theatrics. It's not really helping. And then there was some conversation, and then I dropped an article, New York Times from a week ago in there. And then John calls and said, well, it wasn't the best time, it wasn't sensitive, they really worked hard on crafting this. And it was a lot of big negotiation, there was a lot of feelings about it. And I said, well, but we can't talk about it here. I get it, and I wasn't being rude, and I know because I've talked to Simone about this. He didn't know it. He thought I was like throwing her under the bus or something. But even but we have to be adults here. No. And we should be following the best we know. And we have more information. But this really isn't that useful. So why are we making people do it? Why are we going to do it if it's really that useful? And then someone said, well, clients say they want it. Well, we're going to educate clients. This isn't making you safer by testing our temperature. It isn't. So, back up. Then you're right.
Hi, Jim. It's Jen. How you doing?
Hey, Jen.
I just wanted to confirm that I clicked the right link. Can you tell if I'm signed in as a panelist, or do you need to do anything on your end?
I think you have. Can you? Yeah, it shows that you're a panelist.
Oh, okay, perfect.
It shows up in
Excellent.
the middle screen. That's what you are.
Okay, thanks so much.
Sure. And to everyone else who has joined already, I see there's already about 15 folks who have registered. Thanks for being here, for being early, Johnny on the spot. We will start at the top of the hour. So you can do what you need to do between now and then if you'd like, and we'll get going at 3.
Hey Jim, this is Julia. I'm wondering if attendees have the ability to use the chat box to chat with all attendees or just panelists.
That's a good question. I was hoping they could chat with everybody, but let me see what the what's happening down there. Does it show that you can't chat with anyone but panelists?
Oh, great. Thank you to the attendees putting the messages in. That it works for everyone.
Cool. Yeah, there's like a little thing you have to set up that can stop this or allow it. And I'm glad I did the right thing because I want people to say hi to each other. And it looks like folks already are. So since we're talking about this and we're all here a little early, feel free to chat and to let people know who you are and to connect with people. And we'll ask that you use this chat throughout for questions and comments. We'll be monitoring and doing our best to elevate them and discuss them. And wow, we have someone from Australia. Hello, Australia. Amazing. And while we're still seeing people join, we're still a little bit shy of the hour. There was a question on whether people could be seen or heard. Everyone is automatically on mute. And since this is a Zoom webinar, no one's videos are showing. So the only videos you will see are people who were invited as speakers and presenters. Just as an FYI, that is one of the particulars of the webinar platform that Zoom has. However, we will be asking folks to share their thoughts and comments in the chat or the QA function. And we will be referring back to that to make sure that your ideas and your questions are being relayed to the entire group and to the panelists so we can answer them. The other thing I want to say is feel free to connect in this chat and to chat amongst each other and to, we try to make this as real life as possible. And if you were sitting in a big conference room, you'd probably be chatting with your friend a little bit or commenting on someone's slides. Just remember, however, that the chat is recorded. So you might want to be, thoughtful about what you do share in that chat. And someone else I think had asked if we were recording, and we are recording. We will talk about that in a moment, but this webinar is being recorded. Should you be uncomfortable with that, I guess the option for you would be to exit the webinar. If you've already, if you're here, you've registered, we're gonna be sending everyone a recording and we'll be sending everyone the slides. So if for some reason you're uncomfortable being here in a recording setting, you can exit. So I'm hoping you can all see me now. Hello, hello. My name is Jim Pickett with AIDS Foundation Chicago. Thank you for joining us for Thinking Inside the Box, implementing self-testing strategies for HIV and STIs. We still have a lot of people to join us, but I think we have a really packed agenda today. So I'm gonna go ahead and get us started with a little bit of housekeeping, a little bit of background. So first of all, thank you for being here. Let me go to the next slide. So as I was mentioning earlier, this webinar is being recorded, and by participating in this webinar, you're consenting to being recorded. If this is something you don't want to do, you have the freedom to exit the session. And as I said, we'll be sending out these slides and on a recording of this webinar to everyone who registered. So you'll still get the benefit of the webinar. Here is our agenda. We're going to make some welcome remarks in a second. So joining me to make remarks and to help moderate this whole session is Tim Jackson, who is our Director of Government Relations for AIDS Foundation Chicago. And my name, for those of you who don't know me, I'm Jim Pickett. I'm the Senior Director of Prevention Advocacy at AIDS Foundation Chicago. This is what we're going to be covering. So our first discussion is going to be with Julia Zigman from NACCHO, so a national perspective. And then we're going to have some presenters from Howard Brown Health here in Chicago with a more local perspective and local program models. And following that, we'll have another local perspective from Alfredo Flores at Calor. And let me see, my screen isn't advancing. And then we're gonna go zoom out and go back to national with Jen Hecht, who will be talking to us on behalf of Building Healthy Online Communities. And we'll come back to Chicago for some another program idea / model called Screen Time from Chicago House. And then we're going to hear about a little bit of research that's going on, a really interesting research project that's being put forward by the folks at Lurie Children's Hospital of Chicago. So I see that there's people from all over the world here, actually. Hello, Australia. We are giving this a fairly, so the way this webinar is going to happen is we're really looking locally, really looking at what's happening here in Chicago, and then with some national perspectives. We hope people from outside this region find it interesting. But our goal was to get to kind of rally the troops in Chicago to see what more we can do, what's happening in terms of HIV and STI self and home testing, what's happening, what more can we do to improve that. As we talked about in the email that brought you here, you know, COVID has changed the landscape for everybody, and we've had to really think about how we get services to people who, you know, don't want to be out and about, and our clinics have limited hours and availability. So how can we still get people the testing services they need, whether they're on PrEP or otherwise? And so we're really thinking about this in a Chicago context, and we really hope this sort of gets our juices flowing to do better and more, and to be prepared for post-COVID. I have to believe there will be a day that there is a post-COVID. And I think a lot of our folks that we serve, a lot of our communities are going to really appreciate having options like home and self-testing, and will want to take advantage of those well into the future for their convenience and for their privacy. I want to share a few quick logistics and light housekeeping. So I've mentioned this a couple times, but it bears repeating. Please use the chat and the QA to ask questions, comments on content, and connect with each other and network with each other. We are going to share the slides with you. We will share the recording, and there is my email. Should you need to contact me for any reason. Now I'm going to just see, Tim Jackson, my colleague and partner in crime on this webinar, is here. Tim, if you could unmute yourself and show us your beautiful face. Would love to hear some quick opening remarks from you from an advocacy, policy, and government relations perspective.
Hello, everyone.
Hi, Tim.
Hi, I apologize for my tardiness today. That is not normal. I have been having internet issues all day today, and I am currently using my cell phone while I troubleshoot my computer. So first of all, thank you all so much for coming, for participating in today's webinar. So looking forward to the discussion and the information that's going to be shared. It's something that we have looked at from a policy angle on how we can best provide the resources to our organizations across the state that allows us to be able to still reach people through a pandemic and post-pandemic when it gets to HIV, STI testing from home. And so it's something that we want to constantly be mindful of adding more things to our prevention toolbox. And so I am so looking forward to the discussion today. We'll be chatting some things down that we could possibly use in our policy work in 2021. So with that, I'll turn it back over to Jim. Thank you.
Thank you, Tim. And Tim and I are going to be kind of tag teaming on moderating and following the chat. So Tim is going to be paying attention to the chat during this first section over the first 3 presentations, and then we're going to flip roles, and I'll be monitoring the chat and making sure that we're able to bring questions to the presenters. But before we do that, I want to do a couple of really quick polls. So here we're gonna once again test my ability to use technology correctly. So these are the questions you're gonna get. I'm gonna pull up this first poll. And please answer as fast as you can. This is just a quick boom, boom, boom. And we'll wait till we get a high percentage of folks in. Still going. We're at 74%. Oh my God, push it over. Can we hit 80? I don't know that we're gonna hit 80. So close. All right, I'm gonna end it. So here are the results of the first poll. Does your organization provide home or self-testing services for HIV? So 36% of you say yes, 58% say no, and the rest, it's not clear. So we have one more poll. I'm gonna launch this. Does your organization provide home or self-testing services for STIs? We didn't get to quite 80% of the viewers last time, so let's see if we can get there. We're at 60, 63. Oh, just hitting 70, so close. 75, 76, 78. Oh, we need a couple more people to push that over. 79. Come on. I would vote if I could. Oh, we did it. Fabulous. So let's see what the results are. So far fewer, so much fewer folks. There's 14% of you who answered are doing home or self-testing for STIs. And the majority are not, 67%, and then there's another percentage that don't know. So I think this kind of gives you a sense that there are some folks doing some interesting things. We know there's a lot of challenges to doing these. But what we're really hoping to do today is, oh, we already did that one, is really get people interested and excited about this and think about how their organization might be able to implement some of these ideas. We're also, let's be really clear, we want to call for accountability and ask for support from our state and local health departments who should be really leading efforts on this. We recognize that a lot of people in health departments have been assigned to COVID duties. So some of this thinking inside the box is hard to do right now because people are full up on COVID, and that's super important. But the HIV epidemic hasn't gone away, and the need for services haven't gone away, and the need for innovation is clearer than ever. So I think that's some of our marching orders today. I'm gonna stop sharing my screen, and I'm gonna invite our first presenter today, Julia Zigman from NACHO to sort of set the stage for us today from a national perspective, looking at some work that they have done with health departments. Take it away, Julia.
Great, Jim. Thank you so much. Give me one moment and I'll share this screen for everyone. Is everything looking okay?
It looks beautiful. Thanks, Julia.
Perfect. So everybody, welcome. Thank you so much for joining. I know this is late in the day for some people, or maybe in Australia it's early. Not really sure, but I invite everybody to stand up, stretch, shake it out a bit as we dive in. Again, my name is Julia Zigman. I use she, her pronouns, and I am a program analyst on the HIV, STI, and viral hepatitis team at the National Association of County and City Health Officials, or NACHO. So we are the only organization that's dedicated to serving every local health department in the nation. We serve over 3,000 local health departments, big and small, rural and urban, and really everything in between. You can see on the screen here just some of the ways that NACHO supports local health departments. And I want to share this as a precursor, both to encourage you to learn more about NACHO and what we have to offer local health departments, but also to begin thinking about how NACHO can support local health department and community efforts to increase access to HIV testing, empower individuals in their jurisdictions to improve their sexual and overall well-being, and really to reduce inequities. Some of the key work that we do includes training and technical assistance, facilitating peer learning and engagement among local health departments, creating and disseminating tools and resources, and conducting advocacy and policy development. So to dive in here today, I'm going to tell you about a convenient survey that NACHO conducted of local health departments asking about their implementation of self-testing for HIV and STIs. And though we're presenting it from a higher level national perspective, talking about local health departments, a lot of what we'll share today, some of the challenges and key facilitators for implementing these programs, are really applicable across many community efforts and other clinics. So as you'll see on the screen here, I'm talking today about the implementation of self-testing, and you can see that there's a ton of elements that programs need to take into consideration when implementing this strategy, from test procurement to data and monitoring needs. Local health departments and others have shown that there really is a wide variety of approaches to each of these. And also, because I'm the first presenter, I'll give some quick definitions for you all. Non-clinic based self-collected testing programs can look different in a lot of ways, but at their core really involve self-collecting a sample for testing in your home or another private non-clinic location. So when we're talking about HIV testing, we're generally talking about self-testing, where a test is performed by an individual and you receive your results in real time. There's only one FDA-approved HIV test for this. It's an oral swab, and most of the sites that I'll discuss today use that one. When discussing STI testing, we generally are talking about self-collection. And at this point, this means self-collecting specimens and returning these to the laboratory, as limited options really exist for rapid or point-of-care testing for STIs, and none are validated yet for at-home collection. Or a few of them are, but not on a rapid sense. So other presenters will get more into that, and I'm happy to answer more questions about that later. But diving into our survey a bit, we conducted a convenience baseline survey of HIV and STI self-testing options at local health departments, which really provide safety net services for so many people in their jurisdictions. The goals of this survey were to identify common challenges and priority areas for resources, technical assistance, and support overall in developing this issue further. This was a convenient survey that we distributed to some of our networks, including an established volunteer network of survey respondents, some newsletters, our work groups, etc. And we conducted some follow-up interviews afterwards with local health departments who indicated in their responses that they are implementing or developing self-testing programs. I do want to point out that we did this survey back in April and May, so a lot has changed even since then, but we still gleaned a lot of really important information about what it takes to implement these. I'll give you a quick snapshot of our respondents. We talked to 35 local health departments, many in high priority areas for HIV services due to their HIV burdens, and we really got a good mix of jurisdiction sizes sharing their experiences with us. at the time of the survey, as you can see on the screen, the majority of our respondents were not offering self-testing for HIV and STIs, though many were interested. I'm not really going to emphasize the quantitative aspect from here on out because, again, this was a convenient sample and so much has changed since May. These strategies have been developing for a really long time, but they've really been thrust into the spotlight as of late. So resources are starting to come about and there's a lot of interest, as we can see by the fact that there's over 100 participants on this webinar. To give a little glimpse of these programs that you saw in the yes or the in development columns there, of those who offered or are developing self-testing programs, most programs offer rapid HIV testing only, and they plan to distribute these tests via the mail, though some will explore other options such as picking up test kits at their facilities and outreach-based distribution. There's really also a variety of outreach methods in focused populations. Some local health departments were really highly focused on reaching certain populations, such as adolescents or asymptomatic clients perhaps, but others were open to testing anybody who wants it. Now I want to spend a few minutes talking about some of the most common challenges and barriers faced by existing and developing self-testing programs. Two of the really biggest ones that came up were validation and funding. So when I say validation, what I mean is that for STI testing, particularly gonorrhea and chlamydia, most public health laboratories don't accept samples that were self-collected, especially outside of a clinic. There are private companies that do this sort of thing, but that's not accessible often to the population that uses local health departments, and local health departments don't have that funding. But when you talk about reliability, there's a lot of questions and concerns that folks have about reliability and self-collected testing. And what we like to emphasize is that, especially when aided by sufficient guidance such as videos or illustrated instructions, plenty of literature shows that self-collected testing for STIs is not only feasible, but highly acceptable and it's accurate. So we're really hoping to get some more resources out about that field. I've got lack of funding here that I'm sure comes as a surprise to nobody. Lack of funding really prevents expansion for some of these programs. This in some ways plays out in the limited test options available. Going back to STIs, it's very expensive for many health departments to figure out a way to offer self-testing because of that validation issue. Though later today, you'll hear from Jen Hecht from Building Healthy Online Communities about a really awesome program they're developing to help that. But other funding issues, such as only being able to buy some tests, health departments are having to limit their eligibility or who they market to maybe because they can only afford to buy X number of tests. So other things that came up, there's a limited range of tests available as self-testing options. People want antigen antibody test or a full panel STD. There's some things in the pipeline of development, but right now we kind of have limited options to work from. And then looking at surveillance and follow-up, there's a lot of questions here because by necessity, follow-up and data collection are going to look different when you're not face-to-face. And what we found from our survey and conversations is that health departments are really using some innovative methods to support linkage to care, which others in the, well, health departments and community organizations. So others in the presentations will go more into detail about how that works for them. The last three I can touch on briefly. Low buy-in is an issue when you can't get it through the myriad of other things health departments are working on. A lack of staff time, especially during COVID, when developing these programs can take away from other programs, especially as self-testing is just one part of a thorough prevention portfolio. And finally, dissemination mechanisms like ordering and mailing the tests. These can be administratively burdensome. There are many ways to do this, though, that we're seeing at local health departments. So hopefully on your screens in a moment or two, a poll will show up. We saw from our first poll that at least 30 of you all are offering self-testing for HIV and STI. So we're wondering which of the challenges here have been the hardest to address if you had to pick one of them. Oh, never mind, it's multiple choice. List all of them if you like.
Yeah, I hope that's okay. It felt like some of these are going to be, a lot of people will have multiples, so.
Absolutely, and that's what we found in the survey as well. So thank you, Jim.
Sure.
We'll keep this open for 20 seconds.
I'm just very pleased with myself for knowing how to do this, I have to say.
It's definitely an art and a science to figure out Zoom.
And then, Julia, once we get these results in a few moments. I think there's a few questions. I know I saw Tim has a question or two that are coming from the chat that we may be able to get answered right away, if that's
Oh,
okay.
great. Yeah, definitely. There's also time for Q&A at the end. Oh, I had the chat box hidden. Here it goes. Okay, so if you want to close the poll and show the results, I can talk about these.
Sure, I'd be
A
happy
question,
to.
great question, was what exactly constitutes self-tests? If I have a patient do their own swabbing, so oropharyngeal, rectal, or vaginal for gonorrhea or chlamydia or an other STI, does this count as a self-test? Samara, that's a great question. Yes, that counts as a self-collected test. What you just described is something that happens in a lot of clinics. A lot of express clinics for STIs are using that approach. And I know that some do face a challenge with their public health laboratories in getting them to accept those swabs. If it's done in a clinic, that's generally not what we're talking about when we're talking about self-testing here. What we're referring to is a test that an individual can order or obtain somewhere and do it on their own without having to visit a clinic. For HIV, the rapid tests available mean that you can get your results within 20 minutes, but for STIs at this point, you generally have to follow a process such as what you described and then return that specimen to a laboratory or a health department for them to run their results and share them with you. So thanks for asking. I'm looking at the poll results now. Lack of funding, almost 50% of respondents shared validity, limited range of tests, surveillance, and follow-up is a big one. So these are really similar to what we've seen in our surveys as well. So I appreciate you all sharing. Go on to the next slide for sake of time. I'll blow through this one. We asked local health departments that didn't do self-testing the same question. They had very similar responses: lack of funding, validity concerns, or previous low perceptive need. Now that's changing a little bit because of COVID, which brings me to this slide. We did ask our programs about the impacts of COVID-19 on home testing. And what we found at COVID is really bringing a concept that's long been in development into the forefront. But that means there are still challenges, such as administrative functions like physically mailing the tests are impacted by the switch to remote work that was very rapid. Staff reassignments, and even limited testing supplies. I remember there was a shortage in urethral swabs earlier this spring, and I think that's happening again now. So there's just a few ways that COVID's impacted this. And as I continue to share, I won't pause just for the sake of time, but if you all want to chat amongst yourselves in the chat box, how COVID has impacted your ability or desire to implement self-testing, or for the 30 or so of you that already implement it, how has it affected your program delivery? I would love to see what you all have to come up with later. We did also ask about some facilitators, and especially in these interviews, we identified a few really strong elements that help these programs thrive. Funding, that's self-explanatory. It's always needed, especially when it's sustainable and not grant-based. Established laboratory systems and relationships with laboratories, especially ones that can validate those STI testings, is really key. Having buy-in at your health department or program, it really helps to have a champion organizing and pushing these ideas through and getting the details figured out. We also heard many people talk about their tech-savvy staff that helps. So having people that are familiar with ways to reach folks in an online or at least not face-to-face clinic world. So social media, surveys, marketing, all of that. And finally, having trust and rapport with potential clients is even more important than ever for someone to order a test and report results, and really strengthening those linkage to care that we normally have is important when you're not in person and need to get people connected to what may help them. I'm going to skip that slide for now because I don't want to take up too much time, but thinking about some resources that were identified in our survey as something useful, many local health departments responded that they'd like to know more information about validity, about billing, other cost options, and really that they'd be benefited from some best practices from other people implementing this approach. So this comes from lessons learned, sample protocols, all of that. And we know that sometimes this is so new that it's hard to say successful practices, but even just figuring things out together. So I'll put out a call to action for you all. If there are any resources that have been particularly useful for your health department or community program in thinking through these considerations, we'd love to hear about them. So you can go ahead and share them in the chat box or send me an email at my address listed at the end of this presentation. There's of course still questions that there's a lot more exploration needed in self-testing. A lot of thoughts that we're hoping to develop in this field, such as thinking about billing, how to incorporate telehealth, and some limitation or policy specific limitations to certain populations or areas. Before I leave you all, I wanted to share a few resources that you might find helpful. Following our survey, NACCHO did launch a 3-part series on local health department self-testing programs to respond to the request for best practices and lessons learned from other approaches. So you can read about these 3 programs at our website. I put the link in these slides and I'll share it in the chat box when I'm done speaking. You can also go to the CDC website. They have a great backgrounder on HIV self-testing featuring frequently asked questions for clients and providers, plus a locator. You can also send them an email to get your service listed on that if it hasn't already been there. And finally, the National Coalition of STD Directors has a fantastic webinar series from earlier this summer about testing beyond the clinic that I encourage everybody to take a look at. So that's all I have for you today. I'm happy to take a few minutes to answer questions before we move on to the next speaker. So Jim, I don't know if you want me to look at the Q&A or if you want to moderate any of that.
We're helping you with that. So I have a question that actually came in through email, but I just want to check to see if Tim has any questions in the chat that we want to elevate.
No, I don't see anything. No, I don't see anything right now.
Okay, cool. Well, first of all, Julia, thank you for a really spectacular presentation. You talked about a lot, gave us a big landscape. What do I want to say? You covered the landscape really, really well. But someone actually emailed a question in advance of the webinar, and I think it's a great question, and I don't think you brought it up. But what options are there for getting at-home tests covered by insurance? Just so it is more widely available and not just covered through specific programs. So what do we know about at-home tests being covered by insurance, Julia?
Unfortunately, not very much. That seems to be the question of the month, or the whole season. Who knows? There are limited options for this, not impossible, but for rapid HIV testing. Something I have heard about is using telehealth. I think if providers are able to have a face-to-face conversation or appointment while people are doing testing, I have heard of some clinics starting to use that and try to have a provider conversation and be able to bill for that interaction, but I don't think there's a way to bill for the tests themselves. That's something that I'm not sure if other people on the call can speak to, but something we're definitely looking into, and I can share some more resources with you all after this presentation when we send out slides.
Thank you. And yeah, that might be a good thing for us to collectively work on as we do sort of advocacy with our insurance and payers. I have one more question for you, and then we'll segue over to the Howard Brown folks, Antonio and Carlos. So if you guys want to get ready. So Julia, this question is kind of a chicken or egg question, I think. You know, some of the barriers are well, certainly funding, but lack of buy-in was not a small percentage. So which comes first? Like, is it lack of buy-in? Is that more important, or is the lack? If there was funding, would there be buy-in? Do you see what I'm saying? Like, how is that interplaying, and how can we? If there isn't funding, how do we generate interest with our health departments and our organizations in advance of funding?
That's such a fantastic question and a tricky one. I think, honestly, and I can't speak for all health departments, but having buy-in, or at least, I say at least like that's a small thing, a champion, someone that really is learning about this, thinking about how it may benefit their community, because also self-testing isn't necessarily the right fit for all jurisdictions or programs. There are ways that health departments are partnering with community organizations to offer this, maybe instead of doing it themselves. I think something that we can all do together is really find information and share what we know about how self-testing options can expand access to screening and really complement a health department or program's existing strategies to prevent and detect HIV and other STIs, and then chase the money after that. It's hard to say that knowing that the money doesn't always come. The health departments that talked to us in our survey shared that some had grant funding, but more it was using some of their prevention funding that was already allocated in their HIV department, or finding some leftover general funds from their health departments, which is far and few between, I realize. But having the buy-in and kind of teamwork to figure out where and how this may fit within your organization, I think is a good place to start.
Well, thank you very much for a beautiful answer, a beautiful presentation. Let's give Julia lots of virtual love. Yay, thank you so much.
Thank you, everyone. I'll stop sharing my screen now.
And we'll make sure that Julia is looped in on any follow-up questions or that may come up through the chat. So now I would love to bring on Carlos and Antonio from Howard Brown Health, who are going to take our focus to a very local perspective and a local agency's programming around this area. So Antonio and Carlos, if you'd like to share your screen. Show us your beautiful slides. Show us your beautiful faces.
Awesome. Can we see the slides now?
We can see the slides and we can see you.
Perfect. Hi, everyone. I hope that your day is going well. My name is Antonio Elizondo. I also use the name Tony, so feel free to use either. I use the pronouns he, him, his, or they and them, anything respectful. And I'm the manager of Sexual and Reproductive Health Outreach Services at Howard Brown Health.
Hi everyone, happy day. My name is Carlos Fragoso. I go by any and all pronouns with respect, and I am the coordinator of the Sexual and Reproductive Health Outreach Services at Howard Brown Health.
Cool, so let's get into it. Before we start, we want to acknowledge everyone for the extremely needed work during these stressful times. It's really important. So kudos to everyone. We just want to give everyone a round of applause, clap on the back, and say thank you for the work that you're doing during this time to make sure that our communities are staying healthy. A little bit about Howard Brown. So Howard Brown's mission statement is that we exist to eliminate the disparities of healthcare experienced by gay, bisexual, lesbian, transgender people through research, education, provisions of services that promote health and wellness. We have 7 major programmatic divisions: primary medical care, behavioral health, research, HIV, STI prevention, youth services, elder services, and community initiatives. Over the past 4 years, Howard Brown has had some major expansion. So 4 years ago, we moved from being just on the north side to expanding to the south side at our 63rd Street clinic. Shortly after expanding to our 63rd Street clinic, we went from, I think, 4 clinics to 13. So that was like a really exciting time for us. We also, in 2019, launched 2 express clinic models where we offer just HIV and STI screening. And so we have one on 55th Street in the south side and one in Oak Park at our Brown Elephant out in that location.
All right, so before we get started on introducing our program and our services and things that we've kind of covered, we do want to gauge from the audience and see where you all are at in terms of what barriers you've either experienced with implementing services such as at-home programs. So we have a couple options here, whether it's related to grant funding, not accepting these to be counted towards your scopes, whether it's a lack of funds necessary for the implementation or lack of staffing, or if you don't have any barriers at all. We do want to hear from you all. So if you could take about a minute to answer this question, this poll, and feel free to sound off in the comments and add any kind of extra commentary that you have when it comes to barriers in implementing the service.
And Carlos, this is my bad. I did set up this poll. I am really sorry. It's a beautiful poll. So please, folks, if you would leave your answers in the comments, or in the chat. Just feel free, fire it up. Again, my apologies to my friends at Howard Brown. I missed this one.
No worries, that's okay, Jim. I think we all anticipate some technical difficulties along the way, especially
Here we go with one.
we're all learning the Zoom way, right? Cool, so thank you everyone for chiming in on the chat. We're gonna go ahead and move forward with the presentation then, if that's okay. Cool, so in response to physical distancing and the pandemic that's at hand, Howard Brown launched a few different initiatives. We launched our community care tents. So we have 8 community care tents where we offer COVID-19 screenings to different community members. 2 of them are in partnership with other community centers. The rest are at some of our brick and mortar locations. And then we also have 1 location that's a mobile unit. And so we move the mobile unit around to different disenfranchised neighborhoods on the south side of Chicago. We also moved to launching a robust amount of telehealth services. So quickly after instituting physical distancing and trying to respond to the pandemic, we started launching primary care, behavioral health, psychiatry, dentistry, case management, health education, and support groups all through telehealth. So that was really cool. Today, what we're going to be talking about is the at-home prevention program. So the at-home prevention program includes HIV and STI screening at home, mail delivery for condoms, lubes, dental dams, safer injection kits, cloth masks, PrEP referrals, and then we're also going to talk a little bit about our online outreach restructuring around COVID-19.
And just before we get started with that, I just want to also go into a little bit of detail of what the outreach team specifically did in response to COVID-19. So similar to what the agency's response, which is very swift and quick for them to implement very safe practices, our team traditionally does HIV and STI screenings around the city of Chicago, along with hosting community events, both in the city and suburban Cook County. So we understood that the suspension of these services was needed in order to keep the safety of our patients and our staff safe. And through all of this was the birth of our at-home prevention program, which we'll get into in just a second. And just more recently, Howard Brown has identified a new model in which the team can safely return back to offering services. Although we have not resumed altogether, this initial model is our way of kind of re-entry into community.
Cool. Thank you, Carlos. So a little bit about our at-home prevention program. The staff involved are here listed. It's 7 folks. The different team members play different roles. So there's a little bit of an oversight guidance role that's a little bit more led by me, the manager, Chad Hendry, our director, and Liz Thompson, our associate director. On the front line, we have Carlos Fregoso, who does a lot of the daily activity coordination and kind of does a lot of the leadership when it comes to the daily activities. Javier Chapa is one of the team members that's a health educator. Their role is really to do a lot of the QA, check over submissions that we receive from clients, and process orders daily. And then Mario Heggs is our social media specialist. They focus on doing the outreach that's needed around this program and making sure we get the word out there. We launched the program back on April 13th, 2020. So that was pretty quickly. I think we started adjusting our services around March 15th in response to COVID. So by April 13th, we had launched this program as we recognized that outreach had been out for almost a whole month already, and clients definitely needed those services because they're still participating in sexual behaviors, right? In May 2020, at the end of May 2020, I should say, we recognized that there was quite a bit of demographic information missing that we were collecting. So that's when we decided to increase the questions that we were collecting. By July 2020, we included safer injection kits and cloth masks. And by September 2020, most recently this month, we're launching our partnership with My Lab Box to bring not just HIV testing, which is what we were doing at first, but HIV and STI screening. A little bit about what's available to order. So now with My Lab Box, our partnership, which we'll talk about in a little bit, we can do HIV and STI panels. So that includes HIV, gonorrhea, chlamydia, and syphilis screening. At first, we were only doing the OraQuick at-home test kit. We also offer condoms in a variety. So we offer the FC2, we offer extra larges, the traditional assortment, and also latex free for those who are allergic. We have lube in a bit of a variety too, water-based, silicone-based, and then water-based with aloe. We have safer injection kit supplies, which is listed out below. We include this with every request for safer injection kits. And then with all orders that are requested, we'll include a sex and COVID handout that's mailed out with them. We'll also include, for the at-home screening packets, an email that has an instructional video, the sex and COVID handout, HIV risk reduction handout, and like any tools that are necessary around accessing those services.
Awesome. So here's the flow chart that we have created for the at-home prevention program. As you can see, it initially starts with the patient submitting an order through our online platform in Smartsheets. Once that order is submitted, our staff member will review all the information in Smartsheets along with the information that is in Healthvana, and make sure that all that information is verified correctly in our EMR. Once the team member can verify that, they would then place an order and ship the packet to the patient's address. The patient will then receive the testing packet screening kit itself, along with an email from our agency stating the next steps, safer sex reduction packet, as Tony had just mentioned, along with information on sample collections. So the patient will have this information with them. They'll have the self-collecting kit. And once they self-collect, they will mail those contents out directly to the lab. And then there's a couple routes that can come back based on results. So once the lab processes the patient's specimens, if the results are negative, then our staff member will then upload that information into the client's chart in Healthvana. The patient will then receive notification that the result is negative and it is something that they can access continuously through their Healthvana profile. If the results come back positive or anything that is positive that warrants treatment or care, our health educator will then contact our linkage to care team and our nursing staff in order for them to connect with the client to offer treatment and care. So we won't upload any positive results into their chart unless we first directly contact the nursing staff, who will then get in contact with them for treatment and follow up with them. I know there's a question that came in terms of how long the lab takes to process the specimens. So versus an at-home test. So for example, if someone submits for the My Lab box, after the lab receives the specimens, it could be anywhere from 2 to 5 days for them to process those results. As opposed to if they were doing an OraQuick swab at home, they would get those results immediately after the 20-minute test is processed at home.
Awesome, thank you, Carlos. I can't monitor the chat while I'm presenting, so thanks for keeping an eye out on it.
Awesome, so now we can go into a little detail about what technology we're using. As mentioned before, Smartsheets is an online data collection tool that we are using. It's super easy to manipulate, so we're able to create a form in English and Spanish. It is HIPAA compliant, so we are able to ask all the demographic information that we are looking to capture through our program. More information and kind of like an example of that is on this screen, but if you go to hardbrown.org/prevention supply, you can see, for example, what questions we are asking. Along with that, we are using Healthvana. Healthvana is a pretty cool tool that has been used in our walk-in clinics along with the Express clinic currently. And it's an online health portal that folks can sign up for. And it's really important when it comes to this program because we're able to use that platform for folks to sign off on consent forms so that they are able to receive services, consent for services through our agency. Along with that, it gives them the opportunity to interact with health educators, talk about their visit, leave feedback on it, and also access results at any time for any visits that they have with our My Lab box or with just the agency in general. And along with this, we've also created an email and a phone number extension that is specific to our program. So if folks have questions, comments, concerns, follow up on their orders, if they're looking for anything, if they want their shipping to be discreet. Those are all modes of communication that we can have with our patients.
Thank you. So to dive in a little bit more to our MyLabbox partnership. So MyLabbox is a third-party company that we're utilizing. They utilize a referring provider at Howard Brown to offer these types of screenings and then to provide the results later. So it's important to note that because we're using a referring provider, that provider only has ability to offer healthcare in the state that they have the capacity to. And so we're only able to offer the HIV and STI screening panel to people within the state of Illinois. The MyLabbox panel that we selected that's custom to Howard Brown is the HIV, syphilis, chlamydia, and gonorrhea panel. So for HIV and syphilis, we do a dry blood spot collection. So people do a self-administered finger prick, place 5 drops of blood on a card, and they're gonna ship that card into the MyLabbox lab. For the chlamydia and gonorrhea screenings, we do oral and rectal swabs as well as a urine collection. And then I think there were a few questions earlier on shipping time. It takes 2 to 3 days for the client to receive the sample collection kit once the order is placed. Again, we do require consents prior to this being sent out. Once the client receives it, they have as much time as they need to send it back. But after they've sent it back, it'll be 2 to 5 days post receiving the kit at the MyLabbox lab to receive results on the Howard Brown end or the agency's end. So 2 to 3 days to get to the client once the order is placed, and then 2 to 5 to return once the samples have been sent in. Yeah.
I do want to answer a quick question about if anything comes back with a positive test, then yes, confirmatory testing is performed. So we do follow the same protocols with the agency as we would if anything does come back positive.
Thanks, Carlos.
And can I jump in with a couple more questions that are on the kits?
Yeah, absolutely, Jim.
So one was, what is the return rate for the kits? And is MyLabbox covered by payers or by the client? And how much does it cost?
Sure. So return kits, do you mean like what exactly?
So what is the return rate? So if that kit goes out for someone to collect their samples, what's the rate of return when they come back to you? Do you get 100% back? Do you get 80% back?
Thank you. So that information is still pending. Because we just launched in September, mid-September, we're currently on the 22nd. We have a lot of orders that we just recently processed. So we don't have any that have like completely returned yet. We do have some that have shipped out, but we're still awaiting the return. So that data will be coming to you all soon. Go ahead.
Yeah, a lot of people are asking about costs.
Cost, cool. So let me cover that as well.
Okay,
so
great.
The full panel, the cost is $140 through MyLabbox per screening. So it's HIV, syphilis, chlamydia, gonorrhea, the swabs and the urine collection is $140. I believe for just the STIs, it was $120. And for HIV only, it was $60.
And so where is that, where is the funding coming from? So for your program, are clients bearing this or who's bearing the cost?
No, so this is replacing our outreach model. So we did want to make sure that it was free of cost to every client that accesses. We are very fortunate that Howard Brown has the capacity to incur these costs at the time. And so they are free of cost to clients and Howard Brown's incurring the costs.
And one more question, there's a lot on this. So I'm gonna let you continue after I ask this question and then
Sure.
just be ready for more. So someone's asking, can the health department medical director function as the provider for MyLabbox to make that referral? I think that's what they're talking about.
Mm-hmm.
Can the health department medical director function as the provider for MyLabbox?
So I don't know if I have the answer to that. Carlos, do you by chance?
From my understanding, the medical provider has to be either with the agency that you are a part of, because when we are submitting orders, we have to select a provider specific to where that lab is going to be processing those results to. So we have to have a medical representation, medical leadership. So because we do it in-house, We only know of having medical providers that are able to do that through in-house, but that could be something that we could look into as well and see how that works with partnering with outside agencies.
Yeah,
Thank
I
you,
would
guys. And
probably
we'll
also
hold these
recommend that they
questions.
reach out directly to my lab box if they wanted to like ask any of these questions that might be specific to their agency. Cool. So a little bit, if there's any more questions. No, yes, Carlos?
Let me see. So for the return rate for the old method using OraSure kit, off the top of my head, we had maybe at least 4 to 5 kits that were returned. At most, I would say for the most part, if anything were to come back, if it was just the shipping error, or if it was something that we can just resend it out, for the most part, we found that we were able to resend it out.
Cool. Okay,
And
let's
there is,
then we'll get to some questions in a second, unless there's something pressing, Jim.
it's about my box again. So what type of messaging, if any, do you use during the shipping times to inform patients to perhaps refrain from sex or how to manage sex? So after they've given their sample and they send it back, is there any kind of guidance for them to refrain or to think about their sexual behaviors until they get the results of the test?
I think we don't have anything specific in terms of post sample collection behavior guidance, but I do know that in the prevention packet that we created, we are specific with what these window period is for each type of test that people are taking, so that they understand what that window period is for the HIV, for the syphilis, for the gonorrhea and chlamydia. And we do have our phone number and things that are open for folks to contact. We have had folks who got in their kit, had a lot of questions, and we've been working with them through like that way. But for the most part, we try to give the information through those at-home packets that we send out.
Mm-hmm. However, now that that's been mentioned, it might not be a bad idea to include in the future in our sex and COVID packets that we usually email out, as well as just like any instructional stuff that we'll include. Cool. So a little bit about our online outreach restructuring. We do a lot of geosocial mobile application outreach. So our health educator specialist, social media specialist, Mario Heggs, will take a hotspot and an iPad out into different community neighborhoods. And they kind of just drive around, post up in different neighborhoods, get on the profiles for a little bit. We do very passive approaches. We don't necessarily message people or tap people. We kind of wait for them to approach us. On Growler, we are able to do something called a shout. And so shouts are really cool because you can reach a 5, 10, 25 mile radius, depending on what you select. And the message goes out to all the users in that radius on that platform. In addition to geosocial mobile applications, we also do social media platforms. So we're active on Instagram and Facebook. On Instagram, we do some posting, we do some stories. That's kind of like the general of what we do. On Facebook, we've been able to do the same. So we've done some stories, some posts, and then we not too long ago, during National HIV Transgender, HIV testing awareness for transgender folks, we did a Facebook Live. And so we invited a panel for individuals to come together, kind of talk about the importance of HIV screening, and then how we had the program available. In addition to that, we've been able to take advantage of some online articles who were able to share the resource. So the Chicago Reader, Windy City Times, and WBEZ Radio were all very kind to do an excerpt on the new service that we had and how it was accessible to a variety of clients and community.
Awesome. So now that we kind of touched on the program itself, we do want to highlight a couple of data points with the program itself. So here you'll be able to see, based on the launch date of April 13th until the last Friday of September 18th, we've had a total of about 20 states of clients who have been submitting orders. This also includes Canada and Puerto Rico. Along with this, we did notice that with the top 10 zip codes that we were servicing, a lot of the folks that were submitting orders, there were a lot of trends in terms of zip codes that were aligned with the high prevalence HIV rates in the city of Chicago based on the surveillance data report. And so those are some trends that we've been seeing with our program.
In regards to race, ethnicity, and gender, like I kind of mentioned earlier on in a few slides, we didn't start collecting deeper demographic details until about the end of May, entering June. And so you'll notice that we have some high numbers in unknown because that was within that time period. So within April and May, we serviced about 239 folks that we weren't able to collect deep demographics on besides name and age. As far as race and ethnicity, you can see that we have quite a variety across the board. And then for gender, we noticed that we saw 269 cisgendered male MSMs. We saw 26 cisgender female LGBTQ identified folks, 14 transgender folks, and 18 gender nonconforming folks. So it's been really cool to see that we're servicing quite a variety of clients across Chicago and North America in general.
Yeah, and so here you're able to see a little bit of a breakdown of, on the right-hand side, a map of the places that we've been sending supplies to, and a little bit of a breakdown of all of the actual pieces that we've been sending out. So since the launch date, we've sent out about 377 at-home rapid HIV screening kits. Again, this is specific to the OraQuick, the OraSure self-swab. We've also sent out over 6,361 pieces of condoms, of a variety of condoms, over 2,900 packets of lube, 226 cloth masks that were donated to our agency, which we've been giving out to the community, and about 112 safer injection kits. Again, this is for anyone that has submitted orders from the start of our program. And so now that we are venturing off into do more of My Lab Box, we are noticing that we have about 100 folks who are in queue for processing, which we are connecting with to submit those orders for.
Yeah, and I do want to note that the 102 that we do have in process were collected probably between August and September, because we had a soft transition where we stopped offering the OraQuick at-home test kits and moved to the My Lab Box preparation. And so now we're finally able to start servicing some of those clients.
Here's another breakdown. Something that was interesting for us to notice was on the left-hand side of the Chicagoland map, we are seeing folks ordering from areas in which we traditionally do outreach in. So South Chicago, north of Evanston, and then even west around Berwyn. And then on the right-hand side, you'll see a larger Midwest map of the service areas.
Cool. Some learning opportunities or challenges that we face. So like we had mentioned with the at-home rapid HIV screening kits, we were missing some data collection at the onset. So we didn't have like a lot of demographic information. We quickly learned to change that. And then we also were missing results, which is why we've switched from the OraQuick test kit to now offer the My Lab Box partnership. When we were sending out the OraQuick test kits, they're pretty easy to self-administer. It comes with a box. It has like a slide deck that you can flip through. It's really easy, step-by-step. You self-swab and then you get your results in 20 minutes, which kind of leaves you without the need to see a health educator or be with a health educator when you're doing that. We also tried to circumvent this with doing Zoom sessions with clients whenever they were receiving the kits, but we did get some feedback that clients weren't necessarily interested in Zooms because of the trust factor. So even with putting a lock on the room and making sure you needed a passcode and things like that, clients still didn't completely trust who was on the other end. So like you all see me here, you may not know if there's someone to my right or my left off screen, and that was of concern to some of our clients. Client interest for Zoom was also a barrier. So clients just weren't that interested in taking time out of the day for a Zoom. They recognized that they were able to get their results on their own, and so this didn't seem as useful. We did have about 5 to 6 clients who did take advantage of Zoom sessions and did really appreciate the opportunity to sit with a health educator and kind of go through any of the questions they had, but that didn't really happen as much as we had clients receiving the services. I did forget to add something on this slide when I sent it in, but I also wanted to discuss that one of the challenges was the lack of funding and ability to count our at-home prevention services activities for some of the grants that we already are awarded. And so that definitely was a challenge and barrier that we weren't able to use some of the funds from our funding streams, and we weren't able to count these activities towards our grants that we're trying to make efforts on. Some possible future expansion. So Howard Brown is looking into possibly offering some at-home rapid pregnancy screenings through this program. That'll be in the works. We've also looked into and are still seeing what pursuit looks like of safer smoking supplies. So something that would cover the tips of something that you smoked with, or safer snorting supplies. So different colored like straws or things like that so that people don't use the same materials. Cool, and that brings us to a close. Any questions? Open the floor up.
Hey, Antonio and Carlos, thank you for a really great presentation. And obviously so many questions and they keep rolling in. So I think we're gonna just take 2 quick ones, and then if you all wouldn't mind answering in the chat, so we can move on to the Calor presentation from Alfredo. So first, do you have any positivity data from this program?
None yet.
So you're waiting on that, great. And then the other one was someone giving you lots of love. Thank you so much for sharing the experience with this platform. They're wondering if there has been any change in My Lab Box's ability to do extragenital NAT testing, given the shortage of Aptima tests.
We haven't heard of that yet. Carlos, have you heard?
We haven't heard of it yet, but I think because we have pre-purchased a handful of these test kits as an agency, we are going to still be in contact with My Lab Box to see if that's going to affect any of the ones that we have pre-purchased, or how the shortage is going to affect the processing of any of the ones that we do send in.
Yeah, like Carlos mentioned at the onset, we allotted, I think, about 450 screenings for clients.
So again, Antonio and Carlos, thank you so much. This is such a rich presentation. So many exciting things you all are up to. The questions keep rolling in, so I'm going to invite you to answer them and engage in the chat. And now I would like to introduce Alfredo Flores from Calor. So if you'd like to go ahead and share your screen, Alfredo. Bye, Antonio.
Hello,
There we go. Hey, Alfredo.
how's everyone doing? Let me set this up. Hi,
Thank
everyone.
you
It's
so
Alfredo.
much.
Thank you. Can you all hear me and see the slides?
We can hear you. The slides, you might want to do presentation view so it's a little bit bigger. They seem a little small to me. Although someone else said it's good.
Is this?
You don't have a ton of text on your slides, and it's not tiny. So folks, let us know. Yeah, it was a little blurry, but now it looks like it's sharpened up. So let's see how this goes. Go ahead, Alfredo. Thank you.
All right, thank you, Jim. Hi, everyone. My name is Alfredo Flores. I am the Program Manager of Prevention and Education Services at Calor. A little bit about Calor. We are located in Humboldt Park area. We recently moved as of January 2020. Our organization has mainly focused on serving those live at risk or living with HIV, primarily who identify as Latinos. So we work a lot with undocumented individuals, and we also work with Spanish-speaking individuals as well. So I think, COVID has affected our nonprofits a lot, or organizations, in the way we do services. So the way it's affected Calor, Actually, our facility was closed from March 15th all the way to June 8th. So about 3 months we were actually closed for services, and our office was completely closed. All staff was working from home. During those 3 months, we were able to, strategize a couple of things and see how we can, still provide services, but we were still closed for 3 months. Calor staff are currently, even right now, we're still alternating times in the office, which still affects our ability to provide services. We've also gotten feedback that some clients don't feel comfortable even accessing our facility because of COVID. There has been a little bit of, some hesitation in getting tested. And then also one of the biggest things that has affected Calor services is that summers are typically, I'm sure almost every organization gets the most testing done in the summer. So because Calor typically, attends large scale events like festivals, carnivals, concerts. And then this year we had to kind of strategize, how do we provide testing, because people are like mentioned in previous presentations are still getting tested, are still wanting to get services, and obviously still having sex. So I think it's really important. It was really important for us to resume service as soon as possible. One of the ways that Calor initially began providing services is that we partnered with a organization called CORE that does COVID testing all over Chicago. We've decided to partner with them and do HIV testing. So even today, I was rushing home right now to be able to present as we just left their event. But they provide the COVID testing outdoors, and we provide the HIV testing right next to them in our tents. As you can see, here's a small picture of like our tents and how we provide the services as well. And we still have to follow COVID protocols and make sure we pretty much implemented whatever CORE, the other organization that does COVID, we implemented the way they do testing to the way we do testing as well. In relations to at-home testing and how has Calor been able to adjust our services, is that we basically provide HIV testing through our mobile unit. So we have, we actually have access to a mobile testing van that we've recently actually purchased because of COVID in around May. We purchased the van, and we were able to basically meet clients at their home or the nearest intersection to provide services. Some of those services include HIV testing, condom drop-off, STI testing, and we also can refer to PrEP and other medical services related to HIV. Currently, we are still doing testing in Chicago and surrounding suburbs as well. Services are provided through our testing van. Typically, we actually adjusted or modified our testing van to make sure that we follow protocols in terms of to protect both staff and clients from COVID. Some modifications can included adding ventilation, PPE, COVID screening, and other protective barriers like plexiglasses into our van. We don't have a huge van. The van is similar to that one, just in blue. It has one space to test. So we pretty much made sure that if anyone were to access our services, that they were still protected from COVID. Jim, I don't have access. I try to present. I don't know if anyone has questions. So if you have any questions, please leave them in the box. But yeah.
Sure, yes, we're happy to follow the chat for you, Alfredo. So someone was asking what STI test you do perform?
So we do we collect the urine sample, and we also do the mouth and anal swab for the
Right.
STI testing.
Thank you. You're getting
so
some.
Then now, go ahead.
No, go ahead.
Perfect. So then, so how is testing done? So basically, our first step, we schedule clients through text or call. We ask clients if they're comfortable calling us or texting us. We also get a lot of people interested through our social media. Calor has been actually very active on our Instagram and Facebook page that kind of gets people interested to come into our services. So first, the client will call us or text us to book an appointment. Our staff, will set up a date with them to meet with them. And then after they have identified, obviously their name, their location and time, we basically drive to their location. So once we're driving, our staff arrive, they meet the client outside of the van, and we do a screening for COVID. So we ask them a couple questions around COVID, especially we ask them if they've been having symptoms, we actually take their temperature as well. And we ask them other questions around if they've traveled to any of the hot spots that Chicago has identified. So if any clients, says yes, we unfortunately do not do HIV testing, or we can do the STI testing, but we do not do the HIV testing. Once the client is asked outside and they pass the COVID screening, we ask them to complete the paperwork. We do have our protective barriers. We wear our gowns, we wear our masks, gloves, face shields, to protect our staff. We do ask clients to wear protective equipment, such as the masks, at all times when they're meeting with us. So once they are, signing the paperwork, and we ask them to collect the samples for STI testing in the nearest bathroom. So typically, from my experience, we've tested people right in front of their homes, in the corner of their houses, and sometimes even in front of, I think we had several occasions like Walmart was a really good spot. We asked them to go to the bathroom and collect the specimen, or whatever nearest bathroom is near them, and then come back. So after they've collected their specimen for STI testing, we ask the clients to do counseling with us. We have an option of, if they would like to do counseling through video chat, we have that option, or we also perform counseling in the van. Again, we make sure that the van is equipped to make sure that protecting all staff and clients. So we added ventilation to our van, and we also have a plexiglass that really separates, it's a huge plexiglass in the van that separates the client from the staff member. So counseling can be done, and there's a small little window where we can actually perform the test. So Calor staff performs the HIV test, and obviously, again, keeping the van on, making sure ventilation's on. And once we tested the client, obviously put their specimen in, we actually do testing with INSI test, or depending on the client situation, we also do determine. And then after the client's done testing, after they're given the results, we make sure to sanitize the whole van. That includes replacing PPE as well.
Great, thanks, Alfredo. We have a few more questions, so we can try to answer them quickly so we can move on and try to stay on time here. But I love all the enthusiasm. So how are people responding to the van services? Any kind of feedback you can share about people's experiences with the van?
I think people feel very comfortable that it's near their home. I think right now the clients are not trying to travel far, or even travel to, one feedback that we did get is that a lot of clients don't want to go to hospitals or anything clinic related, because they think right now people who have COVID are accessing those services. So that is one feedback that we've gotten. Other feedback that we've gotten is that sometimes even being discreet, our van doesn't have any branding or any service information. So that's another thing that's appreciated as well with our service.
Thank you. And how long is a typical mobile van visit, Alfredo?
Yeah, so that is actually very time consuming. So it's actually depending on where the clients are located. So we strategize with testing clients in the same location in the same day. But I would say a typical visit would take about an hour. So that includes, say for example, we test the first client at 10. From 10 to 11, we make time just for that client. And then that includes that travel to the next location. So again, it's about an hour.
Okay, Alfredo, two quick questions. One, can anyone get tested if they see you out in the community, or do you have to have an appointment?
We pretty much, if we're out and about and we're near the location, what we do sometimes, we do station our van and we do geosocial. Like one of our biggest ways to get clients has been Grindr. So we have staff members on Grindr, and that's honestly has been the biggest way that we recruited clients.
Okay, and the other question is counseling mandatory?
Yes, counseling is mandatory.
All right.
some COVID-specific modifications that we've made. Obviously, we do the survey for clients. We do not test anyone who meets these following things. So if clients who have COVID-19 symptoms, have had contact with someone who tested positive for COVID, or traveled to the hotspots identified by CDPH. Clients must also wear face masks during the session and staff interaction. So anytime that they're interacting with us, we make sure that they are wearing PPE. Again, staff are required to wear gloves, gowns, face masks, and face shields during the services. And then we are required to make sure that we sanitize the whole area. The door, the couch that we have in the van, the table, the plexiglass, everything is pretty much sanitized.
Alfredo, thank you so much, and thank you for sharing this great program on behalf of Calor. There is Alfredo's information. Please continue to engage on the chat, and I don't know if you can get on there, Alfredo. If not, we can share with you any follow-up questions. But I'm going to now say thank you and ask you to stop sharing your screen and invite Tim to introduce our next presentation, going back to a national level.
Sure. Thank you so much, Alfredo, for that great presentation. We're next going to have Jen Heck, with co-founder and director of Building Healthy Online Communities, to come and present on how to bring home testing to your community. So Jen?
Great, thank you. Just getting the slides up and running. Let's see if it looks like you can see them, and let me just get to presenter mode.
And while Jen is doing that, we're gonna hold questions off until she gets to the end of her presentation. Hopefully that will keep us on time.
Okay, thank you so much, Tim. And thank you, Jim and Tim, for inviting me to join you both, join you all today. So I'm gonna talk about how to bring home testing to your community. I'm hoping that my talk will address and touch on and hopefully reduce or eliminate some of the barriers that were brought up earlier in the NACCHO presentation that I know that a lot of you are experiencing. So just briefly, what is Building Healthy Online Communities? We're a consortium of public health leaders that have been partnering with gay dating apps, working together to support HIV and STI prevention online. We've worked very closely with Grindr, Adam for Adam Growler, and Daddy Hunt specifically to update their profile options so that we can increase sexual health information that's exchanged by users and create a norm around that. But we also work with many other apps and websites. We've created some PSAs. We've worked with Grindr closely on their sexual health FAQs on their app, which have been seen by well over 15 million users. And we launched last year a website called tellyourpartner.org that enables folks to let a partner know that they may have been exposed to an STI and encourage them to get a test. So that's just a little bit about BHOC. This is who some of our partners are on the public health side, as well as on the website and app side. But to jump into this particular topic, I want to give you a little background. So we've worked closely with our partners at Emory University. They do an annual survey called AMIS, which is a survey of 10,000 MSM. It's an online survey. And we've asked about kind of app use among MSM. And on our most recent survey, we found that 75% of MSM reported using a dating app to meet a sex partner within the past year. We also asked a lot of questions about their interest in different sexual health features on the apps, and as well as their HIV and testing behavior. So what we saw was that 22% of MSM who use the dating apps had reported that they've never been tested for HIV, and that well exceeds the kind of lifetime testing for MSM overall as seen by data from NHBS. So we definitely felt like there was an opportunity here to use the dating apps to reach MSM who might not have tested or might not have tested recently. And then we also asked users, about different sexual health features, and there was a lot of interest in being able to order a home test through the app or through a link access through the app. And 77% of users said that they wanted that kind of feature. So we've been building a platform. We have built a platform that is used for this purpose to enable enable community members to order home tests, and they don't have to be on the dating apps, but the dating apps is the primary way that we're promoting it. And then just to talk very briefly about the way the model is set up. We have this centralized ordering platform that we've created. We have partnerships with public health agencies. We work very closely with NASDAD on this project because NASDAD has relationships with all of the different states and many local jurisdictions as well. And then of course, we're partnering with the apps. Importantly, the way we set this up is that a specific individual health department, be it state, local, can sign up to participate to create eligibility within their jurisdiction. And then that creates a free test for users in their area. So where we're partnering with NASDAD is helping us maintain the contracts with our vendors, but also the payment for the different jurisdictions. So that's been working really well. We've signed up quite a number of different state and local jurisdictions, and we're really excited about that partnership. Importantly, I do want to note that it is not necessary to hire any staff to do this. This is the experience on the user side. So for users, in the case that they're on an app and they get an ad or they find a link to home testing, they will be asked just a few questions. And I'm actually going to show a video. Fingers crossed that this works smoothly here. So I will kind of talk this through, but basically you put in your zip code, your age, your sex at birth, and that we're specifically looking for folks who haven't tested recently. So that will help determine your eligibility status. Once you're eligible, you would enter your information to order a kit. It's pretty quick. This whole video takes 2 minutes, so that's presumably how long it would take to order a kit. The kit arrives in a discrete package to the user's home. Here you can see that jurisdictions can choose whether they're going to allow 1 or 2 home test kits for the user. And then you'll see kind of what it looks like for the next steps. They'll get a discrete kit, and then they're asked a few demographic questions about themselves. And that is basically how the process works. Oh, we got some sexual health risk questions here as well. And then where they had their most recent test. And part of the reason we ask this is that we're also interested in sort of complementing clinic-based testing. This was all designed pre-COVID and then happened to launch right in the time of COVID. So I'm gonna pause this. That's the end there. And bring us back to the presentation. Let's see. Okay, so moving on, just a little bit of detail about who can participate. So currently the participation is for folks who are over 18, who haven't had a test in at least a year and are in a participating zip code. We will be moving forward with opportunity of creating more tailoring around that eligibility criteria based on what the jurisdiction wants to do. We often get questions about what happens when an individual tests positive. And again, I did not mention that this is also the OraQuick test kit that's being sent out. So some of the information that was shared earlier is very relevant here. But one thing that's important is that there's several sets of information that go out. So the OraQuick kit itself has some information that's really valuable. There's a video, there's a 6-minute video that is available that kind of walks the user through the process of how to do it. And there's a hotline that's a 24/7 hotline. So if a person is feeling worried, stressed, unsure about how to take the test or how to read the results, or if they test positive and they want to get a referral, that is a really great resource. However, on top of that, we work with the local areas for their protocol and their information that they want to share. So it may be that in a local area, they want to direct folks to get a confirmatory test at a particular clinic, or they have a particular protocol. And so we make sure that we're redirecting folks back to the website where they can get that local information. And then we also, of course, get questions about how much it costs. So we have, the cost is really for the service as a whole, but we calculate it on a per kit basis, which is $46 per kit. And that includes quite a number of different components. So it includes some free promotion through our partners at the apps. And that really has driven the majority of the traffic to the sites. It includes the kit itself, the shipping and handling process, as well as some monthly data reports. And as I noted earlier, it is not necessary to hire any staff and nor to store any kits. So we launched in late March. And since that time, we've gotten some really positive feedback. 97% reported that they would recommend this to a friend, and 94% rated it as a 5 out of 5. We got a lot of feedback about folks who felt like it was reducing their anxiety, or in some cases they had never been tested. And so having access to this kind of service was really important to them. Since we've launched, we have sent out over 2,000 kits. We started with 4 health departments in late March, and we now have 5 states and 19 counties that are participating. Just under a third reported that they'd never taken an HIV test before. So we are really successfully reaching folks who either had never been tested or haven't tested recently. And we're finding about half of the orders are among individuals who are under age 30, and about 40% of the tests that we're sending out are being sent to BIPOC folks. So this is a little bit of what the promotional materials look like. Grindr, one of the partners that we've been working with, has been providing some in-kind promotion. And so this is what a message might look like for a Grindr user on the left here. And then on the right, we're sharing digital assets with our partners. So if they want to do additional promotion on their end, be it free or paid through social media or other means, we're providing them some of those assets. So we're also in the process of launching an STI testing as well. We anticipate launching that within the next several weeks or month or so. It's probably in many ways similar to what was described through the Howard Brown folks. We are not using My Lab Box, however, though. We are sort of building our own portal in partnership with a lab vendor. And we will be offering the same set of services, however. There'll be a client portal for folks to be able to sign back in and get their results. Positive results will immediately be reported to health departments. And in the future, health departments will be able to sort of sign in directly to download the data. That's something that we'll be launching in early 2021. And we are translating the whole site into Spanish and anticipate that should be done by the end of this year. So we will be offering, as noted, the same type of services. So we'll have HIV dry blood spot as an option. We'll also have a full comprehensive set of STI tests, 3-site chlamydia and gonorrhea, syphilis, HIV dry blood spot. There'll be a risk question to assess for hepatitis C. And then we'll also be able to support folks who are already on PrEP and already have a PrEP provider to get their follow-up HIV and creatinine. So I know I went through that really quickly. I know we're short on time, but I have not been able to follow the chat. So if there's any questions from the chat, please go ahead and let me know.
Yeah, thank you so much for that great presentation. We have a few questions. Let me see. Can you break down that BIPOC number, Black, Indigenous, People of Color number, or describe who's included in that group specifically? Are you coding white with another race as BIPOC?
So I don't have that information right at my fingertips because it's I've already put it together, but I can follow up certainly at a later date with that detail.
Okay. And an extension to that question, do you have any data on race, ethnicity, age, or other demographics to understand who's using this platform yet?
Yeah, so I mean, I think, you know, what we're seeing is that 50% of the folks are under age 30, and then there are a lot of folks in their 30s and 40s, but it really is quite a wide range via age. And then, likewise, in terms of race, ethnicity. What I will say is that it's also, as we sign on different counties, where that's changing quite a lot. So, one of the groups that started with us was Montana and Oregon. And so, that's going to look different than signing on groups from, San Diego and other groups around the country. So I think that we're going to see our race ethnicity data change quite a bit based on the participation of the counties.
Okay, a couple of quick questions.
Mm-hmm.
Is the platform in any other language than English for the user?
Right, so we are in the process of translating it into Spanish, and my hope is that we'll wrap that by the end of this year. So hopefully by the end of 2020.
Okay, is the hotline staffed by someone 24/7, or does it also have auto response based on questions asked?
That is, I just want to make clear that that's OraSure's hotline. And yes, my understanding is that 24/7, someone will answer the phone. Absolutely. And I tested it out myself, and I was very impressed with them.
Okay. Would CBOs be able to participate in this program?
So that's a great question. I've had conversations with a number of CBOs that have been interested. I would say that it's somewhat dependent on kind of what's happening in their local area. So it's really designed to be used based on sort of a geographic area. So a certain zip code, say, would become eligible. So that would sort of depend on their situation. Is there already another service available in that area? Are they able to pay for folks maybe within a certain set of zip codes and a certain set of eligibility criteria?
Okay, and final question. What does linkage to care look like for participants?
Yeah, that's a great question. So essentially, the way we've modeled this after some other programs that already have been in existence for the last few years. So the state of Virginia has a home testing program, as does the state of Arizona. And essentially the way we've set this up is that for folks who get a preliminary positive at home, they're directed to get a confirmatory test. And again, it's very much focused on whatever the local participating jurisdiction wants to direct them to in terms of their follow-up. And then at that point is when they would get connected to the healthcare system. And we encourage, the participating jurisdictions to also be looking at their surveillance data. So we're going to give them data on a monthly basis. They can use that and look at their surveillance data to see if those folks were participating with us.
All right. Well, thank you so much, Jen, for your presentation and for answering these questions. If you could get back with us on the BIPOC question,
Sure.
We can make sure we can get that information out.
Okay.
So thank you so much.
Thank you for the invitation.
We will now have Chicago House, Mikey Forbes, Testing Program Manager, to talk about screen time.
Hello, everyone.
Hello.
Pleasure to be here. I will be sensitive to time. My name is Mikey Forbes. I work at Chicago House and Social Service Agency. I am the testing program manager, and I will be talking about our program screen time. So quickly, a little bit about Chicago House. We're a social service organization that supports individuals impacted by the HIV/AIDS epidemic and the broader LGBT community with housing, health, and employment services. I work on the prevention side. So primarily we provide HIV screening and linkage, insurance and housing navigation, teleprep, medical linkage, medication adherence, general support, and referrals to other services like employment and case management. Now, during the COVID epidemic, we kind of stopped providing services for a long period of time. And what we really wanted to do is bring all of our services into a program that could address people mobily. And that really played into the model that we previously, prior COVID, we're beginning to implement, which is the Status Pro language, Status Pro model. So in the field, prevention staff are referred to as Status Pros. The goal of a Status Pro is to provide education, resources, and navigation assistance to every participant so they can leave each engagement updated on their statuses and empowered to address them. So we really are focusing on, your sexual health status, yes, but your mental health status, your physical health status, your sexual health status, your housing status, your insurance status, everything incorporated, really looking at an individual as a whole. Really quickly, you'll notice that beginning in March, we saw a really steep decline in services provided. Now, I'll be honest that not all of this data is extremely accurate at this point. During this period of COVID, data entry has been a little bit wonky, but what I can say is, as we began to build a program that could truly fit or try to address these multitude of needs of individuals, we did come up with Screen Time, which launched early July. And this program, funneled through one phone number and one email, basically introduces the client to the myriad of services that we can provide. And what we do is through our primary engagement is home delivery of HIV kits. So for Screen Time, a care kit contains screening supplies, relevant information, harm reduction supplies, and summer swag. So one of the thoughts that we had as we began to build this program was how to bring some normalcy into all this chaos. And normally Chicago House participates in a lot of large events like Pride, market days, etc. And without that, we really did miss that interaction of just summer swag. So we made sure to include summer swag along with our HIV kits, which really did help make these kits a little bit more appealing. We customize harm reduction supplies, condoms, syringes, sharps containers. We also pick up sharp supplies if necessary. We deliver everything to the client's doorstep. So when somebody reaches out to us through the phone number, we provide an intake, and that intake could be done over the phone or Zoom. And we collect all of our data information. We, screen the client to see what services they'd benefit from, what should we put in that kit, and we truly tailor that kit to that individual. We then deliver it to their front door, and we're, contacting the client, we have permission. And what we found is that not only does this address temperature control, concerns with the mail, all of that, we don't have to deal with that. We deliver it to their door. Also, when somebody may be trying to not advertise to the house that a package arrived for them, we can really pick a specific time that they can receive that delivery. Upon receiving a delivery, what we do is we have a phone or a Zoom call. We talk the client through the home HIV test. We record the result. And then through that phone or Zoom call, they have the opportunity to speak to one of our care coordinators. And a care coordinator is the one who's in charge of really setting the client up, right? If they don't have insurance, getting them enrolled in insurance. If they need a medical appointment for PrEP, for an HIV positive test, for STIs, for anything like that, we will schedule the appointment, and then we provide a free rideshare service. So we Uber the clients to and from their appointments so that they don't have to worry about taking public transit or money. The Zoom calls during testing are not mandatory, but we do really encourage that Zoom call so that when we establish that delivery time, we really want to say, hey, give us an hour, 2 hours of your time to talk through with us. Yes, we send or clinical version. We do provide the clinical version, and we create our own home kits. It's a cost-saving measure, and and it really does allow us to add multiple supplies, as well as we have a video that I would show, but we were running out of time. We did do our own video on how to do a home test in case somebody didn't want to do a Zoom or a phone call. We heard. So when it's establishing confidentiality, one of the first things we do is we ask the client to show us the room that they're in. We obtain either verbal or do DocuSign, depending on a client's technical ability. DocuSign does give us the means to get all of our confidentiality forms signed. We During the screening portion of it, we do talk about, setting up a private space for yourself, et cetera, et cetera. That has been one of our challenges, though, and what we've heard as feedback. And I'll kind of get into that in a minute. So the clients can speak to a medical provider over a telecommunication means. And if they require an appointment, we will Uber them. If they require labs, we will Uber them as well. And then we also do routine delivery of harm reduction supplies. So quick about the model. So it goes from the outreach engagement, and that can come from multiple sources, geosocial referrals, posts and stuff like that. The participant receives an intake, right, over the phone or over Zoom. We collect all of our data information, and then we really inform what that appointment will look like so that we can expedite the process as much as possible, not waste time, and we already know what issues we're trying to address. If somebody is just interested in an HIV test, once that home delivery is done, they provide us with the results over the phone, through a text message, or over Zoom. They can, end that engagement there. So it goes from participant intake to potentially a supply delivery. We have been doing hundreds of condom deliveries without doing HIV testing. If somebody is interested in condoms or syringes, we are doing home deliveries for that. Our goal is to hopefully build community interest, community trust, and so hopefully these individuals will come back to us for other services. If they're interested in HIV screening, they can receive assessment from a care coordinator. From intake, there have been multiple situations where an individual would benefit from just immediately seeing a provider. And we don't want to bog them down with having them go through the process of an HIV test if they're experiencing symptoms, or they would just benefit from seeing a provider immediately. And again, we provide rideshare assistance. After assessment, we make sure that they are linked to care by providing support, reminders, assistance to and from appointments. And then we are always providing referrals to non-medical services at Chicago House and outside that address employment, housing, food, all those other resources. All right, so we began in July. Beginning in July, we started documenting our outreach encounters. From those encounters, how many truly engaged with us? From those true engagements, how many received supplies from us, right? And then how many received a test, or how many received an HIV test delivery, how many results were provided, and how many referred to care. So since we began in July, we have gotten all of our results back either the same day or the next day through text message. We did anticipate having some issues with that, but we didn't necessarily. But what we did notice is that after receiving that HIV test, not many people were interested in further care. And I think that came from fear of seeing medical providers in a clinical setting. So feedback that we received so far, hand delivery has been one of the best selling points. We can make sure when it's being delivered, how it's being delivered. We're making sure that package doesn't sit out in the sun for too long. Also, making sure that they receive their package, that nobody else is picking it up, that it's not being stolen off their front porch, all of those. And then also that the delivery person kind of stays in the area for a while, just in case we do get an indeterminate result, so that they can be there to deliver a new test almost immediately. Same day or next day appointments of delivery and linkage, we really tried to bring that 24-hour model back, even though it's so difficult during this time. We really want that turnaround to be as fast as possible. When somebody is ready, they're ready. So when they're reaching out to us, we want to establish that time for them to set aside to, chat with us, to go through this test and really have the best opportunity to be exposed to the options that they do have. Our challenges, and there have been many, individuals without technology, individual safety concerns, being tested at home with a partner that they don't want them to know that they're doing testing, they don't want their parents to know, their roommate to know, individuals without homes, individuals without phones. We're not reaching individuals who truly would benefit most from our services. I found that the majority of the individuals that engage in our services and those that go through all the way to linkage are those that either have health insurance through school or through some other means, but they've just never navigated their health insurance, especially around PrEP or HIV care. Outreach and promotion has been difficult due to COVID and political climate. We can't go out and post our flyers. We've gotten a lot of feedback that utilizing Facebook is controversial, and putting money into promotion on Facebook is not putting your money where your beliefs are. Working 9 to 5. So individuals who are going back to work, have been working 9 to 5. Our program really serves 9 to 3. Monday through Friday, and that's because providers have limited times. And during this whole time, limited times have really pigeonholed us to really say, client, or participant, you really have to be available during these times. And when that's not happening, we're referring out, obviously, when necessary or when available, but it's just really hard. And then provider availability response, I kind of mentioned that. All right. So let's see, the future. So screen time will become one of Chicago House's engagement strategies. We did find that we are reaching individuals in meaningful ways, but it doesn't necessarily meet the needs of everyone. It doesn't reach the individuals who would benefit from our services the most. So we hope to provide additional rapid screenings in the future to increase interest. We will continue to do regular deliveries of harm reduction supplies. Doing these deliveries have really brought a lot of interest, a lot of referrals. September has really started to pick up for us. And then consistency. This is a new program during a time where everything is starting and stopping. My agency recently moved, so we have a new location. And so there's just a lot of change going on. And I think with consistency and really evaluating our outreach approach to engage more people, and then just pairing this service with others. And I think that's all I got.
Yeah. All right. Thank you so much for going through that so quickly. We have a few questions before we get to our final presentation of the day. I think that Jim put in the box. Thank you all so much for being patient with us today as we try to go through as much of this information as possible. It looks like we probably will go past 5, and we hope that you will be able to stay on the line with us. Quick question. Let's see. Do you have any idea of what the rate of response was for people who actually provided you with their results? They didn't reach out. What does that process look like?
So everybody who received a test kit reached out with their test results. And that's why we really encourage that Zoom or phone call upon delivery. When that didn't happen, all we did was continue to do really soft reaching out to the client and said, hey, have you done this? Could you send me your results? Send me a picture. If you need anything, we're here. But we don't want to do that too much and scare people away from re-engaging.
Absolutely. Next question. We heard earlier about client response to using Zoom for appointments. What has been your experience with using Zoom? Any extra safeguards to establish confidentiality?
So with Zoom, those who have participated in the program have trusted Zoom. Those who haven't did not. And, meeting those needs have been challenging. So what we've been doing is referring individuals who can't fit those programmatic needs to other agencies. We are finally opening up our office so we can revert back to in-house. But in all reality, we put this program together to in light of COVID, and it really does have many barriers in itself. Yeah. So while it does meet some people's needs, it really doesn't meet all.
So great segue to the final question was, is the Zoom call during testing mandatory?
Yeah, so it's not mandatory. We can do phone calls, and sometimes people don't join the meeting. So yeah.
Well, thank you so much again for this information and going through it so quickly and answering questions. So thank you so much.
Thank you.
And for our final presentation, we have from Lurie Children's Hospital of Chicago, Lisa Coons and Nate Nash, to talk about the MLab app, a mobile health intervention to improve access to HIV testing among youth vulnerable to HIV infection.
Great. Thanks, Tim, so much for the intro. We're going to tell you a little bit today about this app and our study. This is Lisa Coons, and I'm a research faculty at Northwestern and Lurie Children's. Nate is going to be joining me in a minute to kind of describe some of the features of this app and of the study. So just a few details.
Excuse me. It seems like your slides are really huge. You only can see a few words.
Oh, I see them.
Is there a way to minimize
perfectly.
it?
I mean, I'm just clicking begin slideshow. So,
yeah, I see them fine.
Oh, are you? Okay, so
yeah.
Maybe it's just me. I'm only seeing like 4 words because they're enormous. For my old eyes, maybe.
I don't know. I'm just clicking start slideshow in PowerPoint, so I don't know.
If everyone else is saying it's fine, so it must be just a Jim Pickett thing. So go forward.
Okay.
All right, cool. All right. So moving through here, so you'll see the logo for the study, the ML there for MLab app. This is a 5-year study. It was funded in 2018, and so right now we're in year 3. And we took the first couple of years to really develop the app and test its usability. And so right now we're in year 3. We started enrollment in the study in February, right? I think it was February we started.
Yeah.
So this is funded by the National Institutes of Health, and it's a 2-site study. So Columbia University is the lead site, and then we're a co-site at Lurie Children's. The PIs on the study are Rebecca Schnall at Columbia and Rob Garofalo here at Lurie, and then also I'm a co-investigator. And the coordinators at Lurie are Nate and Afia Sejwani. So what is this app? This is an app that is designed to promote more frequent HIV testing through home testing. So this was designed before COVID, but it's been very fortuitous, I think, for people out there to have this option through this particular study. So home testing kits are provided to the participants. So the app includes sort of standard HIV prevention information through a simple and easy menu. There are, users are reminded via the app to complete the home test every 3 months. And then the app also has their testing history. So, for people that are like, when did I test and what happened? This logs the history, and so it's helpful in that way. It also includes instructions for the testing and a timer for the test. So that's a feature and there's also a feature that reads the test results through a picture of the test that's uploaded into the app. So the reading of the test itself to kind of read the app is investigational, and so it's monitored by the FDA. So this is an FDA monitored trial. And the app provides an interface to link individuals to care who test positive. So these are the different features of the app. So the aims of the study are to, first and foremost, was to refine the MLab app using an iterative design approach. So as I said, we took that initial period to really refine this app. We did a usability trial. And then once we had tested usability and we found it to be usable, the aim was to develop and evaluate the efficacy of the app to increase HIV testing. So we're in that phase now. It's a randomized trial. So who are we targeting? So cisgender men and trans women who have sex with guys who are HIV negative or unknown status. Focus on the younger groups, so ages 18 to 29, and then focus on people who are not on PrEP and who've not tested recently. So it's kind of that niche population of people who have risk, but they're not on PrEP and they haven't tested recently. So in terms of outcomes, we're looking at HIV testing frequency. In particular, that's the primary outcome. Also linkage to care among those who test positive. And then for the reading of the results, the sensitivity and the specificity of the MLab result compared to confirmatory HIV testing. The milestones are, so far, we completed the usability testing with 20 participants across the 2 sites. And then we launched the RCT beginning in 2020. So it was February, I believe. So this is a randomized trial. So it's got 3 arms. So it's a 2-to-1 ratio in terms of the randomization. So the 3 arms are number 1, the MLab app plus the HIV test kits. So people who get randomized to this arm get the MLab app, and then they all get the HIV test kits. The second arm is HIV prevention information only. So no MLab app and then no test kits. And that's the primary contrast condition. And then the third arm is HIV test kits only. So getting the test kits, but not the MLab app. And so that really isolates kind of the effect of the MLab app itself. And then we're doing follow-up surveys at 6 and 12 months post-randomization to see, how the app worked in terms of, increasing the frequency of testing.
Awesome. Cool. And so quick, I know we're just kind of limited on time. So for the poll, we'll just do sort of an informal. So just for a second, just kind of sit with this question on how much would you trust the interpretation of an at-home or a quick HIV test result by a young person who is not a health educator? And then a follow-up to that would then be, would you trust their interpretation more if it was backed up by an FDA-approved app that could read the result? So next, I'm just going to kind of walk through, in terms of recruitment, the steps that we take to get participants enrolled in the study. So these images that I'm sharing now are things that we've promoted on our MLab Instagram page to kind of walk potential participants through what each step of enrollment would look like. So if someone is eligible or interested in being eligible, first they would schedule a visit with us via Zoom. And I would then mail them an OraQuick at-home HIV test to complete with me over Zoom. I would walk them through that test process, and if the result is negative, we would continue enrolling them in the study and randomize them to one of the 3 arms that Lisa mentioned. If it's preliminary positive, I would then connect them to confirmatory care. That's something that I offer. We can offer in-house here at Lurie. If there's another option that works best for that participant, then we'll just make sure that we get them connected to that as well. Then after they're randomized and enrolled, then they just complete surveys at 6 and 12 months, in addition to completing additional HIV tests with the app if that is the condition that they're randomized into. And so this just kind of gives you a brief screenshot of what the app itself looks like. This is the homepage for the app. So as you can see, there is that timeline that Lisa mentioned that can just help a participant keep on track and just regulate their testing timeline. Since if they are enrolled in the study and they do have access to the app, we are encouraging them to do the at-home HIV test every 3 months, which we do send them those as well to complete. It also is just helpful for them to keep track of how many tests they've already done. And when they are doing their new test, they then can go to this page, and this page is kind of goes over what that looks like. So there'll be a timer that's in the app itself, which will help them to know when their test result is ready. There's a short YouTube video, which is hyperlinked into the app, which walks them through how to do the OraQuick test if they forget or something from when them and myself did it at the screening portion. And then they also can just check this page to see all their different test dates, their MLab results, and their visual results. And why we have the MLab result and the visual result is that sometimes there might be a difference or a discrepancy between what the actual test says and then what the image algorithm produces of the test result itself. Along with these 2 services, these are kind of like the 2 big services the app is used for. There is also services for finding services, so like a locating option, which they can put in their zip code. And then based off their zip code, it lets them know what services around HIV, STI testing and treatment are available to them. Then there's also like a learning page option, which has like pull down options for things that they can quick info that they can learn around PrEP, PEP, HIV, all sorts of different sexual health needs. So some study challenges that we've run into since we've started. Obviously the big one is COVID-19. When we originally designed the study, everything was completed in person. They would come into our offices. I would do a finger prick test and so forth. But since COVID, we have had to convert all visits to remote. And so now what that looks like is if someone is interested and they are screen eligible, I first have to send them that OraQuick test in the mail. Then we go over that test together over Zoom. And if it's negative, we'll just continue to enroll them in the study. Another challenge that we've seen is in people using the test outside of study parameters. So completing the screening HIV test before the study visit. So an instance of this happened where there was a participant where I just couldn't connect with, it was pretty much lost to follow up. And then I get a call out of the blue one day that they had ended up doing this test because they had an instance that they felt they were exposed and just wanted someone to walk them through that process. And then also, like I mentioned, there might be issues with the app reading itself. So sometimes with that app, when you upload a picture, there could be the imaging algorithm could make, even though the result is negative or non-reactive, the app itself might say that the test was reactive. So anytime there is a reactive result in the app itself, though, everyone who is a part of the study team gets a notification sent to their email to let them know there was a positive test result recorded. And then we engage within 24 hours the follow-up process for that. So next steps for MLab, we're going to continue enrolling through April of 2022. I'll also continue monitoring for safety issues. So just making sure that those HIV home test results and those app readings continually improve themselves. And then along with that, just updating the MLab app as needed. We work with Vanderbilt University, who is associating and working with us in developing that app and have been really great in making sure if there's ever any bugs or anything that we get those worked out pretty quickly. And we start to expect results in summer of 2022. And yeah, that's pretty much all that I have as well.
I can address some of the questions that we're getting.
Yeah, I haven't seen them, so.
Yeah. Someone asked about, is this available? So it's not openly available yet because we're testing it in this study, but if you have a person in the Chicago area, for example, or the New York area, and this includes the collar counties, for example, in Chicago, and you think they might be eligible for the study, then refer them to Nate, and we can get them hooked up with the screening for the study. In terms of enrollment, somebody asked, how's enrollment going? It's going well. I mean, we totally were flat during COVID, right? The beginning of COVID, while we got everything into remote format. So we were down for 2 or 3 months, but now we are back up with a bang. And got over 100 people enrolled. So we're getting back on track in terms of our timeline. Most people screen out, based on things that you would expect, like they've tested recently, or they're on PrEP, which is great news for all of those young people out there who are younger people out there who are testing frequently and who are on PrEP. So most people screen out for that reason. In terms of race ethnicity, it could be better. We do have, I think, probably about 50% non-people of color. So we're looking to really increase that, and we're increasing our advertisements to really focus more on people of color. So we're focused on that in particular. Let's see, what's acceptability with the mailing kits? I mean, Nate, more to that. Do you want to comment on that, Nate? Just in terms of mailing. So what's the acceptability with mailing the kits? So do people have issues? Has anybody said, I can't receive the mailing?
Right. So we haven't had any necessarily issues in terms of people being unable to receive the package. We have had issues where people have said, like, we'll both be following that tracking number of their packages. And so on mine, I might say it was delivered. And so I'll follow up with the participant and just be like, hey, I see it was delivered. Can you verify? And sometimes people are like, oh, I see it was delivered too, but I don't see the package. And so sometimes there have been times when I've had to resend packages just because it's somewhere along the way, the test was either misplaced or it was delivered to the wrong address or things like that. But for the most part, there's not really it's been a lot more of a smoother transition than I anticipated when it comes to mailing and securing those packages.
Cool. Yeah. And there's a question about, did you consider people on PrEP but not adherent? Totally. We had a huge debate about that on the team as to whether or not we wanted to include people who are on PrEP but not adherent. And so what we decided is that at baseline, we would screen those people out. But if people go on PrEP while they're enrolled in the study, then they would stay enrolled in the study. So we're really trying to concentrate on those people who are not on PrEP right now. But if they go on PrEP, while they're in the study, they can continue. And I think, our primary motivation for this is really to support younger people, young adults, who have access barriers and, other problems in terms of, or just, intimidated by going into a health center and that kind of thing, to really support them to kind of manage their own health. And, through the app, we're hoping that this will, show some effects for them being able to really manage their own health. And if the testing algorithm, the image algorithm works, I think that will be even more supportive for people to be able to really, picture of their result and see whether or not, what the reading, kind of some support around their own personal reading. There's some evidence to suggest that younger people are have more difficulty reading the test, and the fuzzy red lines that we all know so well. So that's really the purpose, and we'll see how it goes. So thanks everybody for the questions and for just your attention, and props to all my Chicago colleagues who are on the phone, and also to Julie and to Jen, who had fantastic presentations, and I learned some things myself from those, so I really appreciate it.
Thank you, Lisa and Nate, and thank you to all of our presenters. Thank you to everyone who has stuck with us through this 2-hour journey through all kinds of self-testing, home testing strategies that are being used both locally and nationally. We will be following up with slides and a recording, and we'll also be reaching out to panelists who spoke today to see if they have any other sorts of handouts or things that they may be willing to share. We'll plop those all into a folder and send you a link to that. And feel free to reach out if you continue to have questions. I think this has been a really energizing and exciting 2 hours, so much to think about and so much to be inspired by. And I really hope to see our jurisdiction and jurisdictions around Illinois and around the country take up these ideas and, really tailor, really give people what they need, because that's what health equity is about. It's about giving people the kind of healthcare that they need, that fits their life, not something that we try to fit into their lives. So Tim, I would like to offer you the last words before we close out today.
Sure. Thank you so much, Jim. And thank you to all of the panelists and for all of you all for sticking with us for 2 exciting hours, a lot of information. At the outset, I said that I'm looking at this through a very a policy lens, naturally, as a policy guy, and trying to look at possible legislation and additional funding from the state here. So got a lot of great information. Thank you so much for that. And again, thank you all so much for spending time with us today. So with that, that's all I have, Jim.
Everyone have a wonderful day. We're only 9 minutes past the hour, so go enjoy the rest of your afternoon and see you all soon, I hope. Bye-bye.